I'm Dr. Neil Skulnick. Today we're going to talk about the 2021 guideline for the prevention of stroke in patients with stroke or TIA, and this is from the American Heart Association and the American Stroke Association. We won't be addressing acute reperfusion therapy. We're going to talk first about diagnosis, then we're going to talk about treatment, and we're going to focus on their high-level recommendations. It's important to complete the diagnostic workup within 48 hours. On admission, we check an EKG looking for Afib or evidence of MI. We want to get a CAT scan or an MRI to rule out the 10% of people who have a hemorrhagic rather than an ischemic event. Admit someone to telemetry primarily to look for Afib, and then we want to get carotid imaging with either a CTA or an MRA in order to get a good view of the carotid circulation as well as the intracranial circulation and the vertebra-basilar circulation. If we can't get one of these two tests, we can get an ultrasound of the carotids, but it's far less sensitive. Get an echocardiogram looking for cardiomyopathy and valvular heart disease. Long-term monitoring for Afib is a new high-level grade 2A recommendation in this guideline. And what that means is using either an implantable loop recorder, an external device, perhaps even a watch that screens for Afib for 3 months up to 6 to 12 months. And the rationale for this is that the detection rate with long-term monitoring is about 5-fold higher than monitoring just for 24 to 48 hours when only 2 to 3% of people appear to have Afib. That can be up to 15 to 18% over 6 to 12 months. Lab testing, a CBC, PT, PTT, complete metabolic panel, and lipids. Let's go on now to talk about therapy, and we'll divide that into lifestyle and then medications. For lifestyle, let's start with diet. A Mediterranean diet with low salt compared to usual low-fat diet. 2 studies have shown that the Mediterranean diet can decrease recurrent vascular events by 30 to 60%. Exercise. Those who exercise have a 40% lower risk of stroke, MI, or other vascular events after a stroke at 3 years. For individuals who are smoking or who have excessive alcohol intake, it's important to address those issues. Let's go on now to talk about blood pressure management. A blood pressure goal of less than 130/80 is recommended for most individuals with stroke, perhaps slightly liberalized in those with large vessel intracranial disease. The recommended first-line agents are diuretics, ACEs, or ARBs. It's important to recognize that beta blockers and calcium channel blockers do not have evidence of stroke prevention after a stroke and therefore are not the recommended first-line agents. Let's go on now to talk about cholesterol management. Everyone who has had a stroke or a TIA should receive atorvastatin 80 milligrams daily. The LDL goal is less than 70. Therefore, many people, if not most, will need ezetimibe and or a PCSK9 in addition. New in this guideline are recommendations about hypertriglyceridemia. For those that have triglycerides above 135, we can consider icosapent ethyl based on the results of the REDUCE-IT trial and only think about that in those without Afib because it can increase the risk of Afib. Diabetes. We ought to use a vascular active agent. Typically, that's either a GLP-1 or an SGLT2, but when we think about stroke, GLP-1s and the TZD pioglitazone have data showing that they decrease recurrent stroke. The SGLT2s do not have data on decreasing the risk of recurrent stroke. Let's now talk about antiplatelet agents. For patients with a recent stroke and an NIH SS score less than or equal to 3, or a TIA with an ABCD2 score greater than or equal to 4, dual-acting antiplatelet therapy, that is aspirin plus clopidogrel, should be initiated early in those who do not have their stroke due to Afib, and that ought to be within 24 hours of symptoms if possible, and it should be continued for 21 to 90 days, and then followed by single antiplatelet therapy. Long-term use of dual antiplatelet therapy should be avoided because it increases the risk of hemorrhagic complications. Specific recommendations are made for Afib, and the most important of those are that in patients with TIA, in the setting of non-valvular Afib, it is reasonable to initiate anticoagulation immediately after the index event when Afib is found. For patients, though, who have had a stroke and are at high risk of hemorrhagic conversion, who would that be? That would be individuals with large strokes in the setting of Afib. Then it's reasonable to delay anticoagulation beyond 14 days in order to reduce the risk of hemorrhagic conversion. If patients don't have mitral stenosis or a mechanical valve, then a DOAC is recommended over warfarin. There are some other specific recommendations in different areas. I certainly refer you to the full guidelines for those. I'm Dr. Neil Skolnick. These are incredibly important guidelines for something we see often, and this is Medscape.